Welcome to the Therapist Thrival Guide. My name is Miranda Barker. I'm a licensed clinical social worker, and I'm here with my co-host, Dr. Lucas Volini.
Hello.
And today we are talking about how to know if your client needs a higher level of care and just some of the different, decisions and aspects of the levels of care there are.
And when they need a lower level of care.
Yeah, that's a good point.
How to make sure that your client is receiving the appropriate level of care.
Exactly. Yeah. And to talk about this topic with us, we have Dr. Jasberg with us.
Hi.
Do you want to introduce yourself a little bit?
Sure. I'm Suzanne Jasberg. I'm a medical doctor psychiatrist at Ellie and have had actually experience in every level of care. So inpatient, PHP, IOP, clinic. Not residential.
Okay.
Could still speak to that.
Perfect. What is PHP and IOP? What do those stand for?
Partial hospitalization programs and intensive outpatient programs.
Perfect. Where do you guys want to start with this topic? Oh, and actually, before we jump in, Lucas has a lot of experience with this too, and so I wanted to...
Yeah, so I worked 3 years in adolescent day treatment, and day treatment, well, maybe if we kind of laid out the hierarchy.
Perfect.
There's outpatient therapy, which is once a week therapy. Intensive outpatient, how would you define that?
Intensive outpatient is between 9 and 12 or 15 hours a week. So it's usually 3 or 4 half days of group therapy.
Okay. And then there's day treatment, which is you're in there 5 days a week. There's a embedded school component if you're a minor who's still receiving secondary education. And then for adults, they're just all-day programs. And then there's partial hospitalization, which is similar to day treatment, but it's intended to be shorter term. Day treatment can be anywhere from 6 to 18 months, depending on need. Partial hospitalization is being in a more medical hospital-like setting for full days, but you're not sleeping there. And then there's inpatient, which is more for acute, episodes of impaired mental health, where
short
you just
term.
kind of, short term. You need stability. Once you get stabilized, then they kind of move you down the spectrum. And then residential is long-term treatment for folks who live on the campus around the clock. And so in day treatment, there was certainly a lot of either people who are moving up the intensity of care spectrum, meaning, they've tried outpatient, wasn't effective. They tried IOP, wasn't effective. So then you tried day treatment, or it's people stepping down the spectrum. So there was inpatient hospitalization, then they were in a PHP program, and then they're coming to day treatment from the partial hospitalization program. And so it's a lot about how we assess and determine based upon the needs, the functional status, the intensity and severity of symptoms, whether or not the level of care they're receiving is sufficient to address that. And it gets complex, especially when you start talking about the role that managed care plays and insurance. Because insurance companies are not always aligned with medical recommendations. And these are expensive treatments the more you move up the chain. So
where do we want to start with this? That was a really good overview of here are some of the different levels of care. Let's kind of start at how to know when your client needs a higher level, and then we can kind of take a step back and say when people are doing well at these other levels and taking steps back.
Yeah, and I guess we can start at outpatient therapy. It's most widely practiced intensity of care, and so as far as when you're working with someone in an outpatient setting, we should always be evaluating the effectiveness of our treatment. Is there progress that's measured, that's evident? And if there's not progress that we're observing, how long do we keep them in that state before we have to consider either a higher level of care or, even sometimes this is a matter of a more specialized provider at an outpatient setting. Because a lot of this also comes down to philosophy. Some folks have a philosophy of avoid higher levels of care at all costs. Others, are more quick to get people into a higher level of care to address it before it gets too severe. Because a lot of times in day treatment and PHP and inpatient, there there were symptoms and struggles that were ignored for so long until they hit a breaking point, and so it wasn't uncommon for people to come to day treatment or come out of a PHP program to day treatment that had never even really tried outpatient therapy before.
That's a good point, because I think that, I mean, the way that I kind of had framed this conversation was, moving up as if you like level up. And there are so many different circumstances where people aren't in those lower level of cares, and then they experience, I don't know, suicidal ideation, or they, there's for some reason, or a psychotic episode or something. And so then they kind of shoot to some of the higher level of cares and then kind of walk their way backwards from that.
Yeah, some things are kind of smoldering and kind of build their way up, and then some things are like a crisis. And so your first entry point is hospitalization. And that's true a lot of times for psychosis,
Yeah.
Well, and my understanding too is that it's really hard to get into some of these programs too, like the residential programs or day treatment programs. And so unfortunately, sometimes you have to like wait until it is a crisis, or like you have to reach that point of hospitalization before you can really even get into some of those things.
Yeah, and I wouldn't say it's a matter of like consciously waiting, but that is often what happens. Like if you're in outpatient therapy and your outpatient therapist refers you to a residential treatment program, that's going to get reviewed by the insurance company, and the insurance company is going to say no because you haven't tried IOP or day treatment. So insurance companies want to see you working your way up to higher levels of care, and there needs to be a demonstration that these interventions were not effective. They weren't sufficient to address this individual's needs.
I see.
And so then they can justify paying for residential or even like a PHP program or day treatment because they're expensive, and insurance companies don't want to pay money for this stuff. So that's kind of the typical way is, moving people up. But if you're in outpatient therapy and then you get hospitalized and you're admitted into a hospital for 2 weeks, 3 weeks, then you have the leverage to say we're moving down the level of care. And so that can often be what happens. And so, yeah, it's difficult to jump over levels, kind of on the spectrum. But maybe, like, I'll speak to kind of evaluating levels of care probably up until day treatment, because after day treatment and when you get into PHP, inpatient, residential, that's where there's always a component of medical providers, and it's more of a hospital setting. And so I've been on the end of consulting with folks at that level of care, and then Dr. Jasberg can address kind of what criteria they look for through that lens. And so with these higher levels of care, I think they're most common with children and adolescents. And so at that level, the things that always made day treatment a clear, kind of sufficient level of care for kiddos is it has a lot to do with their environment. Like when they're in an environment that is just struggling to support their attempts to address their mental health, they're going to stay stuck in it. It's going to be difficult for them to progress. And so day treatment becomes their environment. And so it's an initial attempt to provide everything that these kiddos are needing that they're not getting through outside resources. And ideally, in a well-run day treatment program, you don't just kind of temporarily fulfill, that need of a more sufficient environment. But as you do that initially, you're actively working toward trying to set that up in their actual lives in a way that'll be sustainable. And so, one of my criticisms of day treatment, especially for children and adolescents, was always when they don't require a family component, which is pretty common. When I worked in day treatment, I had the opportunity to develop the program from the ground up. They didn't have a day treatment program. They were just starting it. And so I took that opportunity as just what it was, like a really cool opportunity to do things differently. And so I was consulting a lot with all the other local day treatment programs, and I was pretty disappointed by how unimpressive a lot of them were. For one, they wouldn't require a family component. And so, that's all just first order change where you can help this kiddo and place them in an environment where all their needs are going to be met. But then what's going to happen the second they leave? They're going to be put right back into environments of insufficient resources. And that's when we would see them come back, or that would predict, a
Right.
higher probability of them coming back. And then the other one I would just mention too is every single one of them had a policy that the students in the program, I always just called them students, felt it like it was less pathologizing for them. They're not allowed to be friends and interact and engage socially outside of program.
I've heard of programs. I think we've talked about this before, and that's so surprising to me.
Yeah, it's so backwards. It makes no sense. And I would ask all of them why, and it was always just a matter of, well, that's just what the rule was when they started working. Like, it's not examined. It's like they didn't really think about why, and so I was like, well, that's insane. For one, it's like these kids are in the primal years of social development. Two, they're in this program for 6 to 18 months. It's like this is their social system.
Right. I have a quick question, and this might be a dumb question, but my only context with some of these different higher levels of care have been when I was a child protection investigator. And so I was, like that's really the only context I have for this. And are there day treatments for adults, or is that really a kid adolescent thing?
It's for adults. When it's for adults, that's when you're kind of approaching it more from the SPMI, serious and persistent mental illness.
Okay, that makes sense.
But with kiddos, it's things are different with children for obvious reasons. But the piece that really bugged me too about this, that not letting them socialize, but one, again, it's they're deprived of all socialization then, but two, it's like they're doing this anyway. And it's like when you have a rule that they're not allowed to, the only consequence of that is that they're not going to talk about what they do at program, outside of program. And so, one of the obvious choices was opening that up for them to engage, and the product of that was powerful because what it allowed me to do, I did all the process group therapy, was a lot of these kids, they all have disrupted attachments, or many of them do. And that pattern is they'll meet somebody, they become best friends within 3 hours, and they're the best friends they've ever had for like 2 months. And then they have their first conflict, and that's it. Friendship over, I go find my next best friend. When we knew they were best friends, when we knew they were hanging out every weekend, and when we knew that they had that big fight and that disruption in their relationship, it's like, well, guess what? They have to come back to the program with 16 kids on Monday. And so for a lot of them, that was their first experience of not rupture, but rupture and repair.
Exactly.
And that's super powerful and important. And so these higher levels of care, what they do allow for is far more intensive work in how you provide support to the people you're working with, because you're with them all day. You learn so much more about them. Like my assessment and day treatment for me was hanging out in the lunchroom, and just seeing how they engage and interact with each other. It's like that's how you learn about people and who they are as individuals. It's only a matter of time until that fully manifests in all of their relationships to the different people in the program. And so it's ultimately about just, when providers have access to that level of care with individuals, and we can be that much more intensive and thorough, the depth of healing that can take place can be much more powerful. But we're always still thinking about duration and how long they're in there. And so with day treatment, for someone to be in day treatment and then get referred up to residential or PHP, it's pretty severe. Like they can't keep themselves safe.
Okay.
And when individuals cannot keep themselves safe and they're not in an environment that can provide the resource of keeping them safe or ensuring their safety, you need that higher level of care so that professionals can fulfill that role until either, you restabilize their social system along with restabilizing their resources for coping as individuals. And so when we get up to like PHP, inpatient, even residential, I kind of talked about what my mindset was in day treatment. What would you say the mindset of a provider in those settings is? What's the goal? What's the overall philosophy of what you're doing there?
Well, inpatient, it's usually crisis, and it's safety, right? Like,
is it always like suicidal or homicidal ideation?
No, a lot of times, right? That's one of the main reasons for admission. But when you take somebody who perhaps has like a new psychotic disorder, it might be that their thinking is so disorganized that they're not able to stay safe. You're worried that they're going to wander outside without shoes in the middle of the night in the cold, or
Yep.
they're not trying to hurt themselves. They're just disorganized in a way that they can't maintain safety.
And that might even mean like they're not eating. They can't properly take care of and pay attention to their own hygiene and nutrition. Sleep gets all out of whack. So it's like functional status and level of safety.
So, but inpatient is like life or death.
Yeah.
And they're in need of 24-hour care. And if somebody is not able to be safe, but it's not possible for a family member to watch somebody 24/7. It's just not possible. You can't stay awake. You can't be there. So if they can't maintain that level of safety, then they need to be in a setting where there's shifts of people who are there to make sure that they're safe. And then as soon as that resolves, they can step down.
And what does that assessment look like? How do you know when it's been resolved? What are some things you pay attention to?
Well, their behavior, right? So you're observing them. Are they able to be clothed, eat, interact in a way that seems reasonable and logical? And then from a suicide ideation standpoint, they just have to be honest with you. There's no test for, they have to tell you, yes, I can, or no, I can't. And we can't predict. I can't read minds, and I can't predict the future. You just have to tell me. I'll believe you.
And insurance doesn't reimburse for polygraph tests.
Correct.
So Dr. Jasberg is starting/running our intensive outpatient program for first episode psychosis. Could you tell me a little bit more about like how that IOP, like what elements of group therapy or what elements go into that IOP?
Yeah. So I've been working with patients with psychosis for a long time. So I started off at the University of Minnesota in training, but that was also a big focus of this Department of Psychiatry, always has been. And we would stabilize people in the hospital, and then we were pretty heavily involved with the Navigate program and getting that up and running, which is a big research study about stabilization after a first episode of psychosis. But it's outpatient care, right? So there's one doctor visit a week, one family session a week. There's, things sprinkled here and there, and it's very good care. But most of the time, those individuals stepping down from inpatient needed more than that, right? Like, it was great, and it's great in concept, but it seems like there was this interim step that people needed. So, and the content was really good. So my idea was just to take kind of the psychoeducation part of that and plop that in an IOP with process group and with other therapy groups, and give them like a 9 to 12 week period of time where they're getting that level of care before they step down into outpatient. And you could avoid rehospitalization. You could stabilize symptoms that were not completely stable when they left the hospital. The biggest predictor of whether or not somebody's going to stay on a medicine is like how they responded to the first medicine. And so you can't just prescribe a medicine and send them on their way. Like, you have to, like, how's it feeling? Like, do we need to make a change? Like, maybe we need to swap something out. So, like, you have to be really, really engaged in that portion of their stabilization. The families are usually in total crisis and, like, need a lot of psychoeducation and support of, like, this is the plan. This is what we're going to do. This is going to be okay. And so that's where the IOP came from. For psychosis patients, IOP seemed like a much better fit just because PHP is a really long day, right? And so when you have a psychotic disorder, paying attention and concentrating, they just needed a break. Like, half a day was enough. It wasn't really realistic to say, like, you're going to focus and concentrate for 8 hours a day. Like, no.
So is there always a medication management or like psychiatry component to some of these different levels of care?
Our IOP has medication management because I think it's really important. but PHP up has physicians involved.
Yeah.
Or
It has
prescribers.
to.
Yeah.
Yeah, it's the only way. It's the reason health insurance companies pay for it. And that doesn't mean that every single person in the program is required to be medicated, but it does mean that there needs to be staff that can provide that resource for the many people who do, or who will benefit from it. And the whole notion of the spectrum is, like, if you're moving up the spectrum, you're always trying to prevent that person from needing to move up to the next level. If they're moving down the spectrum, you're trying to get them, to keep going with that momentum downward. And so depending on where they're coming from, it's always the goal to provide stability and ultimately to get people back to functioning as independent as possible. And so that's why we need to be aware of these different levels and what they can offer to people so we can do our part in getting there. Because we're not always going to be the one size, or very rarely will we be the one size fits all for everybody that comes into our outpatient therapy office or wherever we are. What would you say, what's the experience of being a provider in a IOP or PHP program?
I love it, but
What do you love about it?
well, PHP is great because you get to know people really well.
Yeah.
Right? They're there all day, every day. And my experience in PHP was with adolescents, and they let their guard down. They're there all, you like learn so much more about them. They're not coming to the doctor's office. Like, you're going and sitting on the ground in a sensory room with them and being like, what's up with Anna or whatever. Like,
Yeah.
so that is really fun, and it's fun to like give them tools to get back to school, right? And similarly with adults to get back to work, because usually they're not participating then in that part of their life. With IOP, it's a little bit longer, so you get to see a bigger trajectory of improvement. It's not so much just like quick stabilization, good enough, right? You get to know them a lot better. And then I usually, and this is maybe a me problem, but I end up usually keeping them in my clinic then. So then you had this like chance to like really get to know them, not just like one 60-minute intake. Like, the whole family, everything, and then they become your clinic patient. So it's developing that rapport and that history with the person. I love that part of it.
The milieu is what it's referred to. And it's incredible.
And again, in our IOP and anyone that I've ever ran, I haven't had that you can't be friends rule.
Yeah.
Right? Because like the point of it is, you have breaks. The breaks are on purpose so that they can do small talk, right? Yeah. And practice social skills and improve negative symptoms
Build
and all
community.
of that stuff. And it's such an isolating disease. And so why would you take an opportunity where this other person understands what I'm going through and then make that taboo?
Yeah. And the amount of trauma bonding that occurs in these programs. And I say that in a positive way. It's like people come into these programs at incredibly distressing states. And, especially when you're a youth, you might think it's just you, but then you meet all of these other individuals that you can relate to and connect with that are having similar struggles, and so much good can come from that. And that's what I mean by the milieu. The milieu is like the ethos of the complexity of social and interrelated dynamics that take place in these settings, because everyone's there and so embedded in it around the clock. Like, when you work PHP day treatment, you're living in it just as much as the clients are. And so it's like you become a part of it, and there's so much more you can work with. And the deeper their relationships with each other get, the more information that gives providers to work with in the here and now of the milieu. And it is so much fun. But one of the reasons I had to leave adolescent day treatment was because my maturity was regressing at such a rapid pace that everybody was growing concerned, myself included.
Well, you grow so close to those kids, and yeah, that's so funny.
And so you're at Prairie Care PHP adolescents.
I was, yeah.
Did you refer to the Anika program?
Not that I recall.
Yeah,
but I was kind of a pinch hitter in PHP because I'm an adult psychiatrist.
That's right.
So I would bop up there when they needed coverage or whatever. But I ended up covering for like a year. But I couldn't do the little kids. I was like, I'm not my jam. Not sure what to do. But a 16-year-old, I can handle.
Yeah, adolescents are great. And that's what I called the program, the Anika program. Anika is one of the 3 noble truths of Buddhism, which represents the notion of impermanence. And like I made this like a Zen center, and everyone was like, you're going to have all of these adolescents in day treatment with behavioral disorders come and start their day in a silent 20-minute meditation.
And you said absolutely.
And I was like, yeah. And they were like, you're insane. That's not going to work. And I'm like, yes, it will. And it did. And it was what made it work, though, was dependent upon whether or not I was in a meditative state with them. And so I learned that pretty quick. And so everyone would get there. They'd come into my big old office, and we would all just take 20 minutes of time in, which is what we called it. That comes out of interpersonal neurobiology. And, it's like you could sit quietly, you could read, you could sit quietly, or you could journal. You could fall asleep if you needed to, like whatever you needed to do. But it was just a matter of coming together, but being nonverbal. And that was always pretty powerful. And the rest of the program, it was all based on interpersonal neurobiology. So even like every hour, they'd move from 1 hour of a therapy service to 1 hour of special education to work toward the bilateral neural integration of left brain hemisphere processes and right brain hemisphere processes. Process group on a weekly basis, psychoeducation, coping skills group, social activities, family therapy, individual therapy. And so when you work in one of these programs, what I would encourage is be creative. Like there are so many things you can do to optimize the opportunity to spend this amount of time with people in need. But a lot of programs just still operate off of archaic models that haven't been re-examined or innovated. So, there's always opportunity and space to do that. Well, I guess I should say depending on your employer.
Yeah.
But I worked for a county, and they let me name a day treatment program the Anika program. So you just have to create a compelling argument.
There you go. I have to run and go be a therapist. But you guys can keep talking.
So we've covered pretty much up to PHP. Inpatient, we addressed as being all about stabilization, assessing for safety, ensuring safety, and then getting them to the next treatment program that's going to make the most sense. How can we explain residential? Because that's kind of a beast of its own.
I see residential as an option mostly for kids, right? And it's when that 24-hour level of care is necessary, but the acute stabilization is the progress has kind of been done, but their home environment or their coping skills are not sufficient to be safe 24/7.
Yeah.
And for adults, a lot of times that's an option that is not residential, but for adults is an intensive residential treatment center, so an IRTS facility, which is like a 90-day step down. That's similar to a PHP, but they sleep there. But it's not locked. Most inpatient hospitals are locked. And so once somebody is able to stay safe and committed to being there, but they're not safe to be alone 24/7, they could go to an IRTS facility.
And for kids, residential, at least in my experience of it, was like multiple, at least 2 instances of going the inpatient PHP day treatment route, but then day treatment winds you back in inpatient, and then it's another PHP day treatment. Day treatment lands you in inpatient again. Then that's when they start thinking about residential.
Right. So
that's
you've
a
demonstrated that
serious
the 24-hour care is just not working.
Yeah, that if we don't,
back.
that they need to be in this secured facility that can ensure safety, and they need more time to be there. And that's a huge commitment because these residential programs, they're not all over the place. Like I had plenty of families that I would work with where the only program that they could get their kiddo into is 2.5 hours away. So it's a lot of time away from your family, which in some cases is what's needed, for at least some duration. In other cases, it's something that's really painful and difficult, for parents to, like I would say the hardest part of residential with, one, it's hell on the kids, Nobody wants to go to residential treatment when you're that age, but it's also incredibly difficult for parents to get behind. But at the end of the day, if there have been those multiple instances of, the continuum of care landing them back in the hospital, if our goal is to ensure safety and get these kiddos through what it is that they're desperate to get through, it's an option that never feels good, but I'm grateful that it exists.
Right. And the inpatient stay, you're thinking more about maybe rapid medication changes. But then when the reason that they're unable to maintain safety is because it's not because their lithium level isn't correct. It's because they need more time to develop coping skills and tools for safety. That doesn't happen overnight. And if an inpatient stay is, 3 to 7 days, lots of people just need more than that. And so that's where residential becomes very, very useful.
Yeah. And these kids have ongoing complex trauma, and that's one of the things I would say to parents too. And they'd be concerned about the duration of treatment, 6 to 18 to 24 months, in some instances. And, one of the ways that I would explain it to them is it's like the traumas that this kiddo has been through and where they're at right now in their development. It's like it's all a product of, 7 to 12 years of ongoing complex trauma that's disrupted their ability to develop sufficiently neurologically, biologically. And given that duration of how long this has taken to fully manifest, it's like it makes sense that the intervention would require the duration of a year, to kind of get them back on track. And so we always have to look at things from the widest perspective of examining what their development looked like and making sense of what aspects haven't sufficiently developed, and to, kind of not necessarily work backward in development, but to go back to developmental milestones that they never quite hit, that they should have hit years ago. That takes time.
Yeah, I mean, you're essentially saying I'm going to take over the neural pruning for this kid.
Yeah, that's a great way to put it, because if you're doing it right, that's what it is. Yeah. That's exactly what you should be doing. Identifying again, what aspects of that hasn't happened that need to happen, and kind of get them as close to back on track as we can. And then from residential, it's the similar. You don't go from residential to inpatient, because that's not how inpatient works, but typically when you're leaving residential, you do look at either PHP programs or it wasn't uncommon for kiddos to go right to day treatment if they already had experience in day treatment before. But, termination and discharge from residential, there's a huge family component there. They really want to make sure that the environment they're returning this kiddo to is prepared, and that, at least the minimum of what they need as far as resources and nurturance goes, there's confidence that that can be provided. But I've seen it work.
Oh, yeah. Yeah.
What are some of your favorite success stories? Maybe we can end on that one.
Well, the bulk of my IOP work has always been with psychosis patients, mm-hmm. which the trajectory is so amazing, like especially when you've seen them maybe inpatient and then in IOP, and then you're following up with them because they're graduated from college, or will they come back and they like have some milestone to share with you, or they got married or had their first kid, right? Like I have patients who have gone through that trajectory with me right now because I'm old.
Yeah.
But I think the other like success of, and why I like this level of care, is because you're taking care of people who are sick, but you're not doing it by yourself. Mm. So you have, I'm doing the medicines, and then there's individual therapists, there's a family therapist, there's people that are running the groups, and they're like, did you notice X, Y, and Z? I said, no, I didn't notice that. But so the teamwork aspect of it is what I think makes it sustainable as a provider.
Yeah.
Right?
Yeah. Because there can be high burnout and turnover in these treatment settings. But the places that I've seen that occur at, where I've, either I'd have supervisees who used to work there, or just colleagues, that worked in one of these higher levels of care, they weren't well-run programs that properly took advantage and leveraged the multidisciplinary work of the team. You know, there wasn't a lot of cohesion. They didn't feel like they were a part of it. You know, they felt more fragmented. And if the provider is feeling that, then the clients are feeling that fragmentation too. But if you have, you know, like day treatment, honestly, that's a high burnout place. But the environment we created at the Anika program, my colleague that I started the program with, she's still working there like 8 years later.
Yeah.
And I think she'd been doing day treatment for like 8 years prior to that. You know, so if you have the right support, and if a big part of it is if you see the nature of the intervention being effective for the people you work with, it's like that will sustain you, because it is some of the most meaningful, important work in our shared profession, is to have the willingness and courage and composure and knowledge and wisdom to provide that high of an intensity of care. Because too often, you know, what we can tend to see is the higher the intensity of care goes, the lower the quality of the provider. And I'm speaking to that more at like the therapist, behavioral support specialist way, where I don't know what burnout looks like with physicians in those settings. Is it also high?
I mean, burnout's high across the board.
Physicians in general, in any field, except dermatologists. They just chop off moles and get paid millions. I shouldn't have said that. Was that rude?
No.
Okay. All right. So, you know, it's maybe to wrap it up, you know, be aware of what all of the options are. As an outpatient therapist, I would say it's essential that you're familiar with the spectrum of care and the continuum of care, because that's the best way to know whether or not we're providing what the person in front of us is in need of. And also to familiarize yourselves with what actually happens in these programs, because when you have a client coming to you, either, you know, kind of stepping down or stepping up, to have an understanding of what their experience that they're meeting you with, you know, kind of looked like for them, and also the coordination of care too. And maybe that'll be my last question for you. As a physician, would you say, what was your experience of like coordination of care, like post-discharge, pre-discharge with outpatient therapists?
I mean, all over the board, right? You have some people who are super involved, and sometimes it's the patient's unwillingness to sign ROIs or whatever. But it's imperative that when you step somebody down, that you describe and communicate what happened, how it went, you know. So like when I was training my medical students and residents, I would always tell them the discharge summary is extremely important, because when you're in clinic and that person shows up and they were just hospitalized, you need to know what we did, why, what our thought process was, what order it went in, and what our thoughts were as we sent them back. If you just provide some garbage of like
a regurgitated discharge summary
and without your thought process or your logic, like that's going to be very difficult for that outpatient provider. So it was always really nice when you could get on the phone with whoever they were going to and do like a warm handoff, and that as a outpatient provider also feels really good.
And I would say that one of the reasons I brought this up is, you know, my experience is supervising folks in these settings, even colleagues. Your master's level outpatient therapist can be like super intimidated by MDs and psychiatrists. And there's almost like this mindset of, I don't want to burden them. They have no interest in talking to me. They're too busy. They're too important. And so I would like to just eradicate that, because I've never met a psychiatrist or MD or physician that has that mindset or attitude.
No.
You show up to work with your patients just like any other therapist does.
Well, and that's why I like being inpatient in IOP, because I have a team and we round and like everybody's input is what's making the care for that patient great. And in the outpatient world, it's the same. Like, you guys know so much about your people, and they might not be telling me something. It could be like really important. So I have tons of therapists' cell phone numbers for clients that are like, did you know this is going on? I was like, I did not. Thank you.
That's great.
Yeah.
Gosh. And that's so easy to just text too.
Oh, yeah. Yeah.
So suggest that, you know, optimize your resources of efficient communication. So I'd say the two big takeaways are, again, just pay attention to, intensity of the level of care and evaluate sufficiently for each of your clients, but also the coordination of care within these programs and also between these programs and other providers is essential, because we're all, at the end of the day, we're all in this together, and if we want to help clients, we do it better, in community and collaboration than being fragmented from one another.
And the other thing I'd say is that if, you're newer to this or just a little bit unsure, like, I'm really used to therapists calling me and being like, can I run something by you? Like, what do you think? So then, are they doing school? They're not able to get to work? Okay, I think we need to bump up, right? And so that kind of collaboration informally is welcomed also.
Yeah, and you can't get through med school without ranking pretty high in conscientiousness. And so doctors answer their phones and they return their phone calls. Could you even sleep if you have like someone you need to call back? Or do you just do it? Yeah. I could not call someone back for years. When it's professional, there's an added incentive. But leverage our MDs. They want to work with us. We're all in this one together. Don't be intimidated. They're all just humans too.
Yeah. Call me.
You want to put out your number? Dox you. All right. Thank you, Dr. Jasberg.
Yeah,
I'm sure, you'll be back for more because it's always such a delight and super informative.
Thanks.